Yeah. Okay, I think the discussion can go on and on. Let's get on to the. I don't have the program.
Yeah, it's Ibrar for
Okay.
indications and
Yeah,
timing.
Ibrar is ready there. Let's have Ibrar without wasting any more time. And then maybe at the end we can have a combined discussion of the various approaches. Dr. Ibrar.
So while Ibrar is putting on his presentation, Dr. Ibrar is one of the first batch fellows from SGPGI, and he's now a senior consultant GI surgeon at Apollo Hospital in Bhubaneswar. Ibrar, please.
Good evening, sir. Can I share my slides?
Yes, please.
Where is that button? Share screen.
Bottom
Okay.
now.
Right. We got it, sir.
Yes. Yeah, we can see it.
One second,
Full screen. Full screen kar lo.
Kar liya?
Yes.
It's full screen here at my end.
Yeah, please go ahead.
Right. The topic assigned to me is surgical management of severe acute pancreatitis, the indications, timing, and the approaches. Speaking, this we have already discussed. The indications of interventions are clinical deterioration with signs or strong suspicion of infected necrosis, ongoing organ failure in sterile necrosis, usually after 4 weeks of onset of the disease, ongoing gastric outlet, biliary or intestinal obstruction due to large walled-off necrotic collection, ongoing pain and or discomfort, and intolerance to oral diet. As this has already been discussed, most of these indications, present day can be managed by non-surgical means. That means by way of endoscopic intervention or by radiological intervention. Most of this can be really handled. Leaving only a very small proportion of patients for surgical intervention. So strictly speaking, this is the exclusive group where the surgery is required. Otherwise, if the radiological or surgical or endoscopic intervention facility is not available, then all those indications would be indications for surgical interventions as well. The exclusive indications are as a continuum in a step-up approach after percutaneous or endoscopic procedure, abdominal compartment syndrome, a very poorly understood entity, acute ongoing bleed when endovascular approach is unsuccessful, acute necrotizing cholecystitis during acute pancreatitis, and fistula extending into peripancreatic collection. Infection is rather rare in the first week, but it goes up to about 60 to 70% by the end of the 4th week. The diagnosis of infection or infected pancreatic necrosis is mainly based on clinical, characterized by fever, leukocytosis, and persistent organ failure that is going beyond the 2nd week. Beyond the 1st week towards the 2nd week. Then elevated levels of serum procalcitonin on 2 consecutive days is very suggestive of pancreatic infection. Then imaging, of course, is the main diagnostic modality for pancreatic infection or the infected pancreatic necrosis. Particularly if you get a picture like this, the air bubble inside this necrotic cavity, inside the pancreatic necrosis, this is in fact the sine qua non of pancreatic infection or the infected pancreatic necrosis. Then, of course, CT-guided FNA microscopy or culture is the definite way of establishing infection. But then, with this again, we come to a very contentious issue or the very sensitive question, that is, what is the role of CT-guided FNA in infected pancreatic necrosis? No doubt this is considered the ultimate proof of infection, but the point is, should it be performed routinely to confirm infection? Answer is, as you'd see in 90s when we were students, in fact, this is almost a fashionable thing to talk about CT-guided aspiration and microscopy to establish infection, and that becomes an indication for surgery. This is when the early intervention of necrosectomy was recommended in a deteriorating patient. But then early intervention is associated with a very high mortality. Therefore, in course of time, this has been abandoned. And the current practice is to wait for at least 4 to 6 weeks before taking up intervention. And this intervention is purely on clinical grounds, not by demonstration of infection on FNA. What I mean to say is, even if you demonstrate infection and the patient is stable, you are not going to intervene or not going to do any necrosectomy, and vice versa. Patient is unstable and you are not finding any evidence of infection on FNA, yet you would intervene. So therefore, the conclusion is CT-guided FNA in infected pancreatic necrosis is an abandoned procedure for the purpose of intervention as of today. Now, again, a debatable thing, intervention for sterile necrosis, because majority of cases of sterile necrosis can be managed conservatively. But then interestingly, nearly half of these patients when operated upon show positive culture. That means even if they don't show signs of infection, yet there is infection in half of these patients. Therefore, ongoing organ dysfunction or intolerance to oral intake beyond 4 weeks, even in sterile necrosis, should be an indication for intervention. Early necrosectomy was recommended with this premise that removal of the necrotic tissue would lead to decrease in the systemic inflammatory response, which in turn would lead to reduction in MOD as well as in the mortality. But then if you intervene early, the demarcation is still not clear. Therefore, you would require more settings to do a clear of the necrotic tissue. And in the process, surgery can induce infection in a sterile necrosis setting. Besides, this has been seen, this surgical intervention in this early stage can aggravate systemic inflammatory response. And this is associated with a very high mortality to the tune of 50 to 60%. Therefore, early surgery really did not serve the purpose it was intended for. This was a prospective studies back in 90s, where early necrosectomy was compared with late necrosectomy. But then this trial was terminated prematurely because of the very high mortality associated with early intervention, 58% compared to 27% with late necrosectomy. So this trial was eventually given up, was not continued. This is another study published in 2017, where the timing of operative intervention at 3 different cutoff levels were compared. Intervention at 72 hours, 12 days, and 30 days, excuse me. And what this study showed that late surgery resulted in a clear survival benefit over early intervention. Therefore, as regards timing of intervention, for at least 4 to 6 weeks before taking up any surgical intervention. If required, if the patient's condition demands, you can switch to or you can fall back on radiological or endoscope intervention beforehand, but not surgical intervention. For surgical intervention, it is preferable to wait for at least 4 to 6 weeks, because by this time the demarcation is clear and the debridement becomes easy, and you can do a more complete job in less number of attempts. Mode of intervention, as we have already discussed, it could be radiological, endoscopic, or surgical. Just for completion's sake, I'll quickly mention the CT-guided percutaneous approach. Basically, this is done for 3 reasons. One is as a definitive procedure, particularly if there is predominantly liquid component in this necrotic cavity, then CT-guided drainage alone would suffice. Or else this could be a bridge approach in the early stage of necrosis when the patient is not doing well. You want to drain out this necrotic collection, then you can fall back on the CT-guided drainage. Or this could be part of the step-up approach as in the practice now. And thirdly, this could be a prelude to a video-assisted retroperitoneal drainage or retroperitoneal necrosectomy. As you would see, you need a tract, and that is the initial tract is established by a percutaneous approach, CT-guided percutaneous approach. trial has already alluded to. And this is comparing endoscopic approach with surgical approach. And this is what the conclusion was, that the new onset and persistent cardiovascular dysfunction was higher in the surgical group. There's no difference in the mortality. Hospital stay was longer in the surgical group, and pancreatic fistula is higher in the surgical group. So it looks like the endoscopy had an edge over surgical intervention in this group of patients. And now coming to surgical necrosectomy, this could be open surgery, could be minimally invasive surgery, which can again be transperitoneal laparoscopic approach, hand-assisted, conventional, robotic, or transperitoneal transgastric approach. Or this could be retroperitoneal approach. This is known by various names like minimally invasive necrosectomy. This is minimally invasive retroperitoneal necrosectomy, so on and so forth. But the most accepted terminology is word, that is video-assisted retroperitoneal drainage or sinus endoscopy. The transperitoneal approach, that the conventional laparoscopy, what we do, the advantages are you can have an access
Dr. Ibrahim,
sorry?
We have Dr. Rajesh and Dr. Pradeep talking about the procedures. I think if you have
I'm not going to
completed
details
the
of that. This
indication.
is a quick mention of this. Yeah.
Okay.
The advantages are this: you can have an access to otherwise inaccessible area, whereas disadvantage is laparoscopy is difficult in the distended bowel, and pneumoperitoneum could be really hazardous in a very sick patients. I think I can show this video if it plays. There's a video-assisted retroperitoneal drainage. As you can see, the initial percutaneous catheter has been placed. This is percutaneous catheter, and this is the guide wire is passed, and this tract would be dilated by using PCN catheter. We borrowed it from our urology department. There's a guide wire in the cavity now over which this PCN catheter should go. This is PCN catheter goes one over the other in the process of dilating the entire tract. Once you have a sizable dilatation, then laparoscope cannula is placed, 5 French cannula. Through which we do a copious irrigation, and then there's a 5 mm scope is passed through that. That is why this is called sinus endoscopy. This is the necrotic cavity, which is, you can see it's a very clear cavity with some residual necrosis here and there. It does not really require any necrosectomy. All that you have to do is leave large bore catheters in the cavity, irrigate, and this loose necrotic tissue would eventually come out. And this is what happened in this patient.
2 more minutes, Ibrahim.
Yeah, I think I did not cover this. This will be covered by our next speaker, I suppose.
Yes.
So this is open necrosectomy, which may be required in a specific, in some patients where there is not much of peripancreatic necrosis, it's only necrosis confined to the pancreas, then you may use this. So this is a recent study that compared minimally invasive necrosectomy with conventional surgery. The conclusion is significant advantage of MIS over open necrosectomy in terms of post-operative multi-organ failure, incisional hernia, neo-onset diabetes, and use of pancreatic enzyme supplementation. But then there was no difference in the mortality rate or the pancreatic or intracutaneous fistulae. So the summarizing presentation, indications of surgery is failure or non-availability of interventional procedures like radiological or endoscopic procedures in patients who require intervention. And the timing is for surgical intervention is at least 4 to 6 weeks after the onset of the disease. And approach in order of preference is retroperitoneal approach, minimally invasive transperitoneal approach, and open necrosectomy. Thank you. This is a recent article which this PG postgraduates can refer to for knowing more about this, surgical intervention and things. Thank you.
Thank you, Dr. Ibrahim. Are there any questions?
The only point I would like to say, what Dr. Ibrahim said, that even if we are reluctant to operate upon these patients in the early stage, but if one of the indications of intervention is present, then one should try to resort to either radiological or endoscopic intervention to tide over that period. That is a very important point which he has made.
Yeah, nowadays we don't talk of indication for a particular intervention, but indication for any intervention. The indications are same. It is just infected necrosis with clinical deterioration. I think that is what the residents should remember as an indication for an intervention. Shall we go on to the next one? Yeah.
Yeah, Ibrar, there is a question from Dr. Anirudh Dhar. How should a colonic perforation be dealt with in a patient with infected necrosis? Should a diverting ileostomy only be done, or should it be combined with a retroperitoneal debridement also?
I would think if you are going in, obviously you'll do a debridement and do a diversion colostomy or ileostomy, whatever the thing you feel appropriate at that stage. It should be both, not just alone. But stoma is a must. That is one thing for sure.
I would even go a step further that if CT scan or the operative findings suggest that colon may be involved in the necrotic process, the wall may be ischemic or suspicious, even if there is no frank perforation, the threshold for doing a diverting ileostomy should be low, because that is what is going to save the life of the patient. And on the other extreme, if the colon is obviously gangrenous and has opened up at multiple places, or there is a large perforation, then some kind of a segmental colonic resection may also be required, because unless that colon is removed, the patient may not improve in terms of sepsis. So colon is a very important organ which has to be considered when dealing with necrosis.